are going to go on to the second part of our discussions on incretins. My name is Professor Tess van der Merwe. I'm an endocrinologist and a bariatric physician. As you can see, I have some furries with me tonight, unavoidably so. They come and go, bear with me. It does add a touch of lightheartedness to a very, very heavy topic. What I would like to discuss with you tonight is how do you position the incretins? How do you position semaglutide? How do you position Mounjaro? It has become such a confusing world. We are dealing with this pandemic of obesity, and every day we have to face decisions, and we have to make those decisions more rational and more logical. To my own mind, I would like to divide it into three sections. The first is who really qualifies for one of the incretins, whether that be semaglutide or whether that be Mounjaro. The second part is why would you give preference to one over the other? They are both good medicines. And then thirdly, how do we handle them going into the future? And how do they fit in with what we would regard as the gold standard for weight loss, which is bariatric surgery? Now, having said that, and before I start with the first 3 points, I have to say that to my own mind, I think to a large extent the more powerful incretin hormones, semaglutide, Mounjaro, will be replacing the balloons and the bands of the past in terms of bariatric medicine. I think their days are counted. So let's start off by who really qualifies. Well, I suppose one could argue anybody qualifies, but scientifically correctly, it would be people with a BMI above 27 and preferably not much above 40. The simple reason for that is that if we look at what we can achieve with these incretins, it would be anything from a 5 to a maximum 18% of weight loss depending on the starting weight. And yes, I've heard of these case studies where they say the person has lost 35 kilos. But it's not about now, it's about where are they going to be in a year or 2 years or 3 years from now. And I think that unless we go about picking our criteria very wisely at the current moment, we're going to end up with a bubble that's going to burst. And we don't want to sink potentially good medicines because we have made bad medical and scientific choices. So, who else then would qualify? Well, you could argue anybody with diabetes, that is a type 2 diabetic, regardless of their BMI, anybody with a diminished quality of life, and anybody with associated problems directly related to their BMI. So how do you pick semaglutide, Mounjaro? It's a competitive market, and there has to be fairness. I think that if the patient is a diabetic with a very high fasting blood glucose, you're quite safe to say, let's go for semaglutide, and we'll take whatever weight loss we get as a bonus. Both these incretins work in exactly the same way. They delay gastric emptying, they will increase insulin secretion, but there's one crucial and very cardinal difference between these two medicines, and that is Mounjaro will stimulate glucagon, and your chances of having a severe hypoglycemic event if the patient has got a fasted blood glucose of around 7 to 8 but still wants to lose weight, it would be preferable. Your risk of a potential very severe, very nasty hypoglycemic event in the event of a lowish, or what I would call a lower fasted blood glucose with a hemoglobin that is not sky high would definitely be Mounjaro. If you've got a patient that is sitting on a couple of drugs already or medicines for their diabetes, yes, then of course semaglutide, or rather the Wegovy component of it, will be a good choice. They both have side effects, but they also have advantages, and the advantages for these two medicines are not exactly the same. There are additional advantages with Mounjaro. There is the fact that you have got a more rapid lipogenesis. You have got a better chance of resolving fat infiltration of the liver, or what we would refer to as NASH, and you definitely may have a better outcome if there is already established coronary artery heart disease. So I think we must be rational and logical, and before you start to implement any form of treatment, work up the patient. For me, it is not acceptable, and that brings me to the third point. It is not acceptable for a patient not to have had a full cardiac screen, not to have had a DEXA, which is a body composition scan and bone density, and not to have had a sonar to indicate whether the patient has got NASH and to know whether the patient's got sleep apnea. I think it is of vital and critical importance that we do a proper workup on our obese population. Too often does it happen that the patient simply walks into the office and walks out with a script, and there is no baseline data, let alone blood tests. There is no baseline data. Nothing has been performed on them. And that is not how a properly set up obesity clinic should work. We've got to gather the baseline information first, and then we've got to sit carefully with the patient and go through every aspect of what would be a pro and what would be a con. Do you stand to gain more muscle mass? Do you stand to gain more bone mass? Which drug would be the better choice for controlling your diabetes? Which drug would be the better for your fat infiltration in your liver? So it's not a simple question of, I'm going to walk into the doctor's office, worse even, somebody else's office, a dietitian's office, and then walk out with a script and feel that you've been serviced and feel happy and pleased with it. We have to start dealing with this pandemic of disease in a very, very mature way. And until now, it has been very haphazard. Who gets bariatric surgery? Who gets Mounjaro? Who gets semaglutide? We have come a very, very long way in the last 10 years. And yes, we are on the brink of even better medications, but we have to implement our boundaries now already. We've got to make sure that when we deal with these patients, we do not set them up for failure, but that we set them up for success rather than failure. And then, to end off with, I want to say, you have to know when to stop. If the patient is a non-responder, please do not keep the patient on the same medication for 6 months. If by 4 to 6 weeks they've not responded, they are not going to respond. Move on. Refer the patient for bariatric surgery to a center of excellence. I hope we're going to have more pleasant video sessions, and I hope that in December we can have some interactive online courses as well. Thank you for staying with me. Good night.